Welcome to today's deep dive. If you are, a clinician, a pathologist, or honestly just someone who's fascinated by the really complex mechanics of autoimmune diseases, we have a very specific mission for you today.
Yeah, we are definitely skipping past the obvious sort of late-stage textbook presentations today.
You're right, exactly. Because we are exploring lichen sclerosis, but the core question driving this whole analysis is, well, it's this. What specific histological criteria do pathologists actually look for to confirm early stage pre-sclerotic lichen sclerosis?
Which is a lot harder to answer than it sounds.
Oh, it really is. And to answer it, we are pulling from a pretty heavy stack of sources. We've got the latest clinical guidelines from the BSSVD, the BSH, UK national guidelines, and the Mayo Clinic.
But the real anchor for this deep dive is this incredible, pivotal 133-case dermatopathology study by Attili and Attili.
Yes, that study is fascinating. And the reason we're focusing so heavily on the early stage here is that established LS is, it's a breeze for a pathologist to spot, right?
Oh, totally. A textbook case is very straightforward.
But early stage LS is, it's an absolute master of disguise in the clinic. And even under the microscope, it's just incredibly elusive.
Right. And catching it early or missing it, that's the difference between an easily managed condition and irreversible anatomical scarring.
Okay, let's unpack this, because before we even look through the microscope, the clinical presentation is what makes that early detection so incredibly slippery.
Yeah, it really is. When you look at the BSSVD guidelines, the hallmark symptom is this intense pruritus, just severe itching.
Which is notoriously worse at night.
Exactly. It causes major sleep disruption. And clinically, you also see this very distinct figure-of-8 pattern of inflammation around the vulva and the anus.
Right. And the bimodal demographic spread complicates the clinical picture too, doesn't it?
It really does. You had these disease peaks happening in prepubertal girls and then again in postmenopausal women.
I was actually reading through those specific BSSVD descriptions, and they use this incredibly evocative phrase for the clinical signs. They call it cigarette paper wrinkling.
Yeah, that's the classic description.
Cigarette paper wrinkling alongside these pale, porcelain white atrophic plaques. Plus, they note frequent purpura, so bruising. How does the tissue actually reach a point where it literally looks like cigarette paper and bruises that easily?
So if we connect this to the bigger picture, the physical architecture of the skin is literally degrading.
Wow.
Yeah, the epidermis is thinning out dramatically, so it's completely losing its structural integrity. And because the tissue becomes so fragile, even just minimal friction shears the underlying capillaries.
And that's what creates the purpura.
Exactly. And in the prepubertal demographic, that purpura and the tearing it can tragically be misidentified as signs of sexual abuse.
Oh, man. That's a really heavy differential diagnosis.
It is, but what's crucial to understand is that the two can actually coexist due to the Koebner phenomenon.
Remind me, that's where trauma triggers the disease, right?
Spot on. Physical trauma to the tissue actively triggers the autoimmune lesions to form right at the site of the injury.
That dual presentation must just be a nightmare for a clinician trying to get a definitive history.
It's incredibly complex.
And the sources point out that even without the trauma aspect, early LS is like a chameleon. It mimics, thrush or eczema or even just postmenopausal atrophy.
Right. And the Attili study actually noted that 14% of their cases presented as completely asymptomatic vitiligoid lesions.
Wait, really? 14% had no symptoms?
No pruritus at all. So you have patients presenting with just pigment loss or patients presenting with severe itching but very ambiguous visual signs.
And standard antifungal or barrier creams just fail completely.
Exactly. And at that point, the clinician is basically forced to take a biopsy.
And the stakes for that biopsy are just astronomical.
Absolutely. Because left unchecked, the chronic inflammation of LS drives severe structural consequences.
Like the labial fusion the sources talk about.
Where the labia minora adhere and actually resorb.
Mm.
The clitoris can become entirely buried under scarred tissue.
It just fuses over.
Yeah. And the introital narrowing can become so severe that it severely impacts the patient's entire quality of life. Furthermore, there is a documented 3 to 5% risk of developing squamous cell carcinoma within those long-standing untreated lesions.
Which brings the tissue sample straight to the pathologist's desk.
The detective of the medical world.
Exactly. But to understand why early LS is so notoriously difficult for them to spot, I was looking at the criteria for classic late-stage LS, and it seems so obvious.
Oh, it is. The established disease is very distinct.
Right. The sources describe this very clear three-zone architectural pattern. At the top, you have hyperkeratosis sitting on a totally flattened epidermis with like a complete loss of real ridges,
That's zone 1, yeah?
and then zone 2.
So zone 2 is the absolute diagnostic hallmark of established disease. Just beneath that flattened epidermis, there's a broad band of homogenized, hyalinized collagen in the upper dermis.
This is the papillary dermal
Hmm.
sclerosis, right?
Exactly. Under the microscope, all the normal elastic fibers are just destroyed. It leaves what basically looks like a dense, structureless, biological wasteland.
A wasteland. Wow.
Yeah. And then zone 3 is this chronic inflammatory band of lymphocytes situated directly beneath that sclerotic zone.
Okay, so if a pathologist sees those three layers, the flat hyperkeratotic epidermis, the sclerotic band in the middle, and the lymphocytes underneath that is a definitive, undeniable diagnosis of LS.
100%. You can't miss it.
So that three-zone pattern seems impossible to misinterpret. How could any pathologist miss that? Like, what is missing in the tissue when the disease is in its early stages?
Well, the problem is right there in our mission statement today, pre-sclerotic. In early stage LS, that middle zone, that papillary dermal sclerosis that acts as the ultimate diagnostic hallmark,
Yeah,
it simply does not exist yet.
because the biological wasteland just hasn't had time to form.
Exactly. So instead of that neat three-zone pattern, the pathologist just sees interface dermatitis.
Which is what exactly?
They observe vacuolar degeneration at the basal layer, right where the epidermis meets the dermis. And the thing about interface dermatitis is that it's a notoriously ambiguous finding.
It looks like other stuff.
Right, it looks almost identical to lichen planus or inflammatory vitiligo.
Wait, I need to push back on something here because there's a massive paradox in the guidelines that we need to talk about.
Oh, the steroid paradigm.
Yes, the BSSVD and the BHHH guidelines emphasize that a clinician should aggressively treat the symptoms with an ultra-potent topical steroid, like clobetasol, immediately.
Right, to get the symptoms under control.
But then the dermatopathology sources explicitly warn that giving the patient a potent topical steroid makes the biopsy practically useless.
Yeah.
So if you're a clinician trying to help your patient stop this agonizing itching while also getting a diagnosis, what are you supposed to do?
It is a highly contentious clinical dilemma. I mean, potent topical steroids like clobetasol are exceptionally effective at suppressing the local immune cascade.
Which is good for the patient.
Great for the patient. But if a patient applies a strong steroid ointment within, say, 2 to 4 weeks prior to a biopsy, the medication actually resolves the hyalinization process.
Here's the evidence.
Exactly. It clears out the inflammatory infiltrate. So the pathologist receives the slide and is forced to look for a diagnostic hallmark that either hasn't developed yet because the disease is too early.
Or has been chemically erased by the steroid intervention.
You got it. And it frequently results in a non-diagnostic pathology report.
Okay, so if the classic hallmark is missing natively or erased chemically, the pathologist clearly needs a completely different set of clues.
They need a new checklist.
And this is where the Attili and Attili 10-year retrospective study of 133 cases becomes so crucial for anyone trying to understand this.
It really is a landmark paper.
They correlated the really subtle microscopic changes with the clinical progression to create a new fingerprint for early pre-sclerotic LS. Let's dig into their specific criteria.
So they identified a specific combination of subtle early features that collectively act as the smoking gun.
What's the first one?
The first major criterion they isolated is basilar infiltration of lymphocytes.
Okay, so immune cells.
Right. In late-stage disease, those lymphocytes are trapped deep in the dermis under the sclerosus.
Under the wasteland.
Exactly. But in the early stage, the immune cells are localized directly at the epidermal-dermal junction. They are actively infiltrating and attacking the basal layer of the epidermis.
I want to zoom in on their second criterion because the study positions it as the ultimate clue for early disease. And it's a grossly vacuolated and thickened basement membrane.
This is where it gets really interesting.
But wait, if the immune system is actively attacking that junction, how does the basement membrane end up thickened? Shouldn't it be destroyed or, thinned out from the attack?
You would think so. But what's fascinating here is that thickened basement membrane is actually the visual evidence of a homeostatic repair mechanism trying to override an active assault.
Oh, it's trying to heal itself.
Exactly. The basement membrane is normally this very delicate, highly organized extracellular matrix. But when the T cells initiate their attack, they cause vacuolar degeneration.
Which is basically cell death.
Yeah, essentially inducing apoptosis in the basal keratinocytes. And the tissue senses this severe structural compromise and frantically attempts to reinforce the barrier.
Ah, so it goes into overdrive.
Yes, It overproduces basement membrane components, but in a very disorganized manner. And that's what leads to that grossly thickened, distorted, and vacuolated appearance under the microscope.
Wow. The tissue is essentially laying down hasty, chaotic scaffolding while under active fire.
That's a perfect way to put it.
And that ties directly into their third criterion, right? Widened dermal papillae and the destruction of papillary capillaries.
Yes. The researchers noted that very early on, even before the epidermis loses its ridges and flattens out, you see this psoriasiform widening of the papillae.
Psoriasiform meaning it mimics psoriasis.
Right. And that widening is another manifestation of that chaotic repair process. The epidermis initially responds to the inflammation by hyperproliferating.
It's trying to grow faster than it's being destroyed.
Exactly.
Yeah.
It drives the ridges deeper and widens the dermal papillae, which visually mimics psoriasis. But concurrently, the immune infiltrate is targeting and destroying the delicate papillary capillaries within those widened spaces.
The blood supply is getting cut off.
Right. And the study noted that as the original capillaries are obliterated, you frequently see the appearance of new capillaries, but they present with abnormally thick walls.
Okay, so if you're the pathologist looking at this slide, the level of precision required here is just staggering.
It's incredible.
You're hunting for a slightly thickened membrane, some basilar lymphocytes, and a few thick-walled capillaries. And that's it. That's what you have to use to diagnose a disease that, if missed, eventually progresses to fuse human anatomy together.
It's a huge responsibility.
But uncovering these criteria leads to an even bigger question. Because now that we know what the specific microscopic footprints are, we need to understand why the tissue looks this way.
The mechanism.
Right. What is the precise immune mechanism driving this specific architectural collapse?
So the consensus pathogenesis of LS points to a T-cell mediated autoimmune attack, specifically driven by a Th1 response.
Okay, so T cells are driving the bus.
Right. The T-cells infiltrate the tissue and release a very specific cascade of cytokines, including IL-1, IL-4, and most critically, TGF-beta.
And TGF-beta is a potent profibrotic cytokine, right?
Extremely potent. It signals the local dermal fibroblasts to radically alter their extracellular matrix production.
Ah, so that explains the eventual shift toward the biological wasteland we talked about.
Exactly.
The fibroblasts are just being bombarded with TGF-beta, so they stop making normal organized collagen and start pumping out that homogenized, hyalinized collagen that becomes the sclerotic band.
That's exactly how the wasteland is formed. But the cellular signaling is really only half the mechanism.
What's the other half?
Researchers have also identified a high titer of circulating IgG autoantibodies in LS patients. And these autoantibodies are not just attacking random tissue, they're specifically targeting ECM1.
ECM1, extracellular matrix protein 1.
Yes.
Okay, so that protein is a critical component of the biological scaffolding. It maintains the structural integrity of the basement membrane and, wait, it regulates angiogenesis too, right?
Yes, blood vessel formation.
So if the autoantibodies are neutralizing ECM1, they are systematically dismantling the skin's structural support network and its blood supply.
Which fundamentally changes how we view the disease, because it explains the most unique dynamic feature of lichen sclerosus.
Which is?
Migration. Most inflammatory dermatoses establish a fixed zone of inflammation, but LS is migratory. The inflammatory band does not stay put.
You know, I was trying to visualize this migration, and it looks exactly like trench warfare.
That's a great analogy.
Yeah, think about it. The immune system establishes its initial front line at the epidermal interface, right? The T cells and the ECM1 autoantibodies are attacking the basal layer, destroying the papillary capillaries.
Right.
The tissue frantically tries to rebuild, creating that thickened, vacuolated basement membrane we see in the early biopsies.
The hasty scaffolding.
Exactly. But as the chronicity of the disease sets in, the front line doesn't hold. The immune infiltrate slowly retreats, shifting gradually downwards, deeper into the reticular dermis.
And it moves down.
Yeah, and as it moves down, it leaves behind this barren, scarred, no man's land, the hyalinized sclerotic zone.
The wasteland.
Right. So by the time the disease reaches the late stage, the active battle lines are buried deep in the tissue, and the upper dermis is just the ruined aftermath.
That is a perfect visualization. And this raises an important question, because that downward shift is the key to the entire microscopic puzzle. Well, the Attili study raised an incredible point regarding the mechanics of that shift, specifically tying it to angiogenesis. Why does the immune infiltrate move downward in that specific pattern?
Yeah, why doesn't it just spread out sideways?
The hypothesis is that the inflammation is actively tracking the capillary basement membranes.
Oh, wow.
Right.
Yeah.
As the superficial capillaries are destroyed by the autoimmune assault, the deeper tissue senses the hypoxia, it's starving for oxygen, and attempts to sprout new blood vessels upward.
Oh, that is a brutal biological catch-22.
Isn't it?
The body is trying to revascularize the starving tissue, but because the autoantibodies are targeting ECM1, the very protein needed for capillary construction, the immune system just uses those new blood vessels as a roadmap.
Exactly. The T cells just follow the new scaffolding downward, attacking the vessels as they form.
That is wild.
It is. And that thickened basement membrane and those thick-walled capillaries the pathologists hunt for in early biopsies, that represents the tissue's desperate attempt to maintain vascularity under constant targeted attack.
It's all connected.
It really is. The downward migration perfectly explains why the classic sclerotic hallmark is absent in the early stage. The front line hasn't retreated yet.
The fibrotic no man's land just hasn't been synthesized by the fibroblasts yet.
Right. The entire conflict is still localized right at the surface interface.
Okay, let's pull all of this together. Our mission was to uncover the specific histological criteria pathologists use to confirm early-stage pre-sclerotic lichen sclerosus.
And we found them.
We did. We know this disease relies heavily on clinical disguise, mimicking, minor inflammatory conditions, while driving a severe bimodal demographic toward potential anatomical scarring and even SCC.
And for the pathologist, relying on that classic zone of papillary dermal sclerosis is a trap, because early on, that zone simply does not exist.
And if clinical guidelines for immediate steroid use are followed, the microscopic evidence might be further obscured.
Right, so the diagnostic burden falls entirely on recognizing the early markers of that shifting war zone.
Right. The pathologist must identify the basilar lymphocyte infiltration.
They have to spot the grossly thickened, vacuolated basement membrane.
They need to recognize the widened dermal papillae and the compromised capillaries.
Because those are the microscopic footprints of an ECM1 targeted autoimmune attack that is just beginning its slow migration deeper into the skin.
And the relevance of locking down this early histological fingerprint, it really cannot be overstated. When a pathologist accurately identifies these pre-sclerotic criteria, the clinician can deploy highly potent topical steroids with absolute confidence.
Exactly. And because the inflammatory front line is still localized near the surface, that intervention can halt the downward shifting war zone entirely.
It stops the fibroblasts from receiving the TGF-beta signals.
Yes, it prevents the permanent sclerosis from ever forming, saving the patient's anatomy and neutralizing the long-term oncologic risk.
It really highlights how a microscopic shift in diagnostic criteria translates directly into preserving macroscopic function and anatomy for the patient.
It changes lives.
It really does. The mechanics of this disease reveal so much about how our immune system interacts with tissue repair. I mean, we've tracked the clinical ambiguity, the histological paradox, and the specific microscopic criteria that solve it.
We covered a lot of ground.
But looking at the mechanisms we just discussed, I have to ask, where does the future of treating this condition actually lie?
Well, I want to leave you with a provocation based on that angiogenesis paradox we talked about.
Okay, let's hear it.
If the primary catalyst of lichen sclerosus involves T cells and ECM1 autoantibodies specifically targeting the basement membrane of newly forming blood vessels, if the disease is fundamentally an attack on angiogenesis and structural scaffolding, we really have to question our long-term treatment models.
Because right now, the gold standard relies on heavy, broad-spectrum immunosuppressive steroids, right?
Right, to paralyze the entire local immune response. But if we understand the exact molecular target, could the future of LS treatment shift away from broad immunosuppression?
You mean something more specific?
Exactly. What if targeted therapies could be developed to specifically shield ECM1 or protect capillary repair mechanisms at the cellular level?
Wow. So instead of bombing the whole battlefield, you just put a shield around the target.
Right. If we can disarm the autoantibody's ability to recognize the scaffolding, we might prevent the fibrotic no man's land from ever being created in the first place.
Completely altering the trajectory of the disease without shutting down the patient's local immune defenses. That is a fascinating thought to end on.
It's the future of dermatology, hopefully.
Well, that's all for today's deep dive. Keep asking those big questions, and we'll see you next time.